sharing your knowledge and experience with us. So ladies and gentlemen, can we have a huge round of applause for Dr. P.C. Minaria. Thank you so much, and moving forward to our next speaker, I would like to invite Dr. Abhishek Rajpopat. And ladies and gentlemen, before inviting him, I would like to tell you about some of his work. So Dr. Abhishek Rajpopat, MBBS, MD, Internal Medicine, DM Cardiology, Consultant, Interventional Cardiologist. He has more than 10 years of experience, performed 300 plus TAVR cases globally and 100 plus left atrial appendage closure cases globally. His technical skills are, he is an expert in the growing field of structural heart disease that include transcatheter valve therapies and catheter-based treatment of non-coronary cardiovascular defects. As an innovator along with TAVR, he is well trained in performing complex structural heart disease procedures. He is an expert in the field of left main interventional and additional complex procedures. He has conducted numerous workshops on interventional cardiology. He has experience in advanced catheter-based treatments for various cardiac disorders. And currently he is consultant interventional cardiologist at KD Hospital, Ahmedabad, and previous consultant interventional cardiologist at Narayan Multi-Specialist Hospital, Ahmedabad, Sterling Hospital, Ahmedabad. So he has done his fellowship, and his achievements are fellowship in structural heart disease at RIGS Hospital, Copenhagen, Denmark, from July 2018 to March 2019. Effects of repeated pregnancy on left verticular muscle mass poster presentation in Cardiocon 2014. And he has echocardiography evaluation of right verticular functions in acute inferior wall myocardial infarction poster presentation at Cardiocon 2015. So ladies and gentlemen, he has attended national level cardiology conferences and conducted intervention surgery workshop. So please put your hands together for Dr. Abhishek Rajpopat, everyone.
Good evening all. First of all, I'd like to thank Dr. Ramawat for conducting such a wonderful educational meet and inviting me all the way from Ahmedabad for this thing. It's been quite some discussion about heart failure. There is one more fantastic topic coming up, and coronary disease has been taken care by Dr. Ramawat by himself. So I'll be discussing about a valvular heart disease. Let's have a case discussion. This is a 78 years old lady, diabetic, hypertensive, history of atrial fibrillation, had a CVA 3 years back. Now she complains of angina on exertion with dyspnea on exertion since 1 month. ECG shows intravertebral conduction defect with left axis deviation. 2D echo shows ejection fraction of 25% with concentric LVH, severe aortic stenosis, high gradients, aortic wall area of 0.5 centimeter square. Coronary artery disease, nothing significant. Creatinine 2.9. Now, if this patient comes to in our lab, 78 साल की महिला अगर कमरे में आती है और ये सब रिपोर्ट लेके आते हैं, हम बोलते भाई जी तारो कहीं को नहीं हुए, है ना, घर जाओ। ये समस्या इस पेशेंट को अगर ऑपरेट करते हैं तो रिस्क ऑफ डेथ, STS स्कोर was 11.2 and morbidity risk was around 44.8. And many of such patients are denied treatment not only in our country, but 20 years back they were denied treatment in Western countries also. Why we are discussing this thing? Because when India got independent, our average life expectancy at birth was 37 years. Nobody was growing old enough to face such kind of challenges of operating such octogenarian, nonagenarian patients, but that's going to be very common nowadays and in coming future. Because before COVID, our average life expectancy at birth was 67 years. So we are going to face more and more aging population who will be requiring such kind of complex surgeries, and they face a challenge. So now if you see the progression of aortic stenosis, between the age of 60 to 70, it's a 1.3% of the population. But once it is more than 70, it is 3.9%, and in octogenarian it approaches 9.8%. Every 10th person who survives the 80 years of age is going to end up in having a severe aortic stenosis. And with every decade, the risk of aortic stenosis nearly doubles. Problem with aortic stenosis is no medical management helps it. And once patient becomes symptomatic, the life expectancy reduces drastically. And only option is replacing the valve. If you see the data from the Western world of AVR in octogenarians, plain AVR operative mortality 13%, AVR plus CABG approach is 24%, morbidity to the tune of 60 to 80%. But once you treat this patient with replacing the valve, they really live a normal life like the people of their own age. So it's a very fruitful therapy if you can replace the valve. That is why the concept of replacing the valve without surgery came into the picture. Such first kind of implantation was done in France, Rouen, by Dr. Ellen Crevier in 2002, and since then now we are in 2018 and 19, we got indication of surgery extending from extreme risk, high risk, intermediate risk, and now even in a low risk patient. Any patient who requires a bioprosthetic valve and aortic position can be offered TAVR, provided these patients are elderly, not necessarily high risk, but if they are elderly, they can be offered. For performing a TAVR, our eyes and ear are the CT scan. We do a CT scan of a heart, which is a ECG gated, and we do a CT aortography, from which we get to know about all the information what we need, from where we are going to puncture, from where our inventories are going to move, and what kind of anatomy we are going to deal with. Once the planning is over, then comes the execution part. In TAVR, planning is 90%, execution is hardly 10%. In angioplasty, people work in millimeters. In TAVI, we work in centimeters. There is a much more simpler procedure as compared to angioplasty. What we do is, we cross the aortic valve, we put the pigtail across, then we take our new valve, position it just like a stent. There is a middle marker which gives us the idea of where our valve is going to end. We rapidly pace the heart, expand the valve. The expanding valve pushes away the old diseased valve and it takes place as a new one and it starts working immediately. And once it is over, if you take a picture, just check their valve is working properly. Typically, this procedure takes around 1 hour in a cath lab, and including preparation time, it takes 1.5 hours. More than 95% of the procedure of TAVR are done under in a conscious sedation patients with a local anesthesia. And now, as an Indian, we have a challenge of having a high quantity of patients with a bicuspid aortic valve. These patients were not enrolled in the trial, but with our growing experience, we are doing successfully the TAVR procedures in the bicuspid aortic valve, type 1, type 0 with equally good results. So this is the case of a type 0 bicuspid treated recently at our hospital. These are type 1 bicuspid with a long raphe, it went well. So what the guideline says currently, in a low risk surgical patient, SAVR, especially if the patient is more than 75, is still the gold standard therapy. SAVR, surgical aortic valve replacement, has been in a picture since decades together. But if the patient is older or if it is not suitable for SAVR, the heart team approach to decide the feasibility of TAVR is recommended by ESC guidelines. And even in a low risk patient who have some anatomical risk factor like history of chest radiation, frailty, pause in aorta, in such cases, the decision about the SAVR versus TAVR should be done with a heart team meeting, especially preferences should be given to the elderly population. So in our routine practice, to whom we offer TAVR, those who are elderly, more than 70 years of age, those who have the previous cardiac surgery like post-CABG, post-valve replacement, patient with a history of a chest radiation, or other major organ comorbidities like liver dysfunction, renal dysfunction, previous history of stroke, severe renal dysfunction, COPD, pulmonary fibrosis. So it's a growing therapy and is approaching more and more areas, and we hope that it should be benefiting our Indian patients as well. Thank you very much.
Thank you so much, sir, for your detailed description. And can we have a big round of applause for Dr. Abhishek Rajpopat? And moving forward to our next speaker, please, ladies and gentlemen, put your hands together for Dr. Dhiren Shah. He is MBBS, MS General Surgery, MCH Cardio Thoracic Surgery, and his topic for tonight is heart transplantation, established treatment in heart failure patients. So, ladies and gentlemen, please put your hands together for Dr. Dhiren Shah.
Good evening, my dear senior colleagues and my dear friends. At the outset, I would like to just thank Dr. Ramawat for organizing this fantastic small interaction meet. We are here to discuss about the heart failure. We are here to discuss about heart transplantation also. So on this evening, my being the last talk, it would be more of a pictorial talk. And I would be discussing and I will be sharing my experience of 29 heart transplants that I have performed in last 4-5 years. So till date, it has been almost said in the medical community that heart transplant is not the established form of treatment because the mortality is high, overall outcomes are not good, and there are a lot of myths and facts spreading in the medical community and even in the general community also. So first heart transplant was done on 3rd of December 1967, and the third heart transplant of world also was done in India. That was in February 1968 by Dr. P.K. Sen. But after that there was a long pause, and after the establishment of the TOA Act, that is the Brain Dead Act in 1994, that we did the first official heart transplantation of India at AIIMS Hospital in 1994. But if you look at the history, in last 25-30 years, we have been unable to achieve the number of heart transplantation procedures in India, which in Western countries, particularly in US and European countries, they are doing almost 3,000 to 4,000 heart transplants per year. Whereas in India, we have not been able to achieve that number. And practically, what are the reasons? Yes, obviously, first and foremost thing is the lack of knowledge, the lack of initiation, lack of knowledge from the medical community also. And more important point was, because heart transplantation is purely dependent on cadaver donation, organ donation. So in India, the organ donation rate itself was very low. If you look at this chart, the organ donation rate is on a higher side, that is almost 6,000 organ donations are done in Western countries, that is the US and Europe. And against that, almost 6,000 or 5,000 heart transplantations are performed. Whereas in India, the organ donation rate has merely picked up in 2012, and now it is slowly increasing in India also. So along with that, the heart transplantation program is also increasing in India. And if you look at the chart, here you can see that the heart transplantations per year that we have achieved is almost 200 to 250 heart transplants per year in India. Right now we are doing, against the organ donation rate of almost 600 to 700 organ donation rate in India. Now, over a period of time, the organ donation has rate increased, and in Gujarat, in last 2 years, the donation has increased by almost 49%. To the tune of that, at one point of time, in last November, December, I did 9 heart transplantation in just 2 months, and of which 3 heart transplantations I carried out in just 1 week. So that is the amount of organ donation that is being performed right now in Gujarat and Tamil Nadu and rest of the country. So I think so the future is good, and these are our data. If you look at, I started in 2016, in December, that was the first heart transplantation. But after that, almost 2 or 3 heart transplantations per year, because again, as I said, the acceptance level from the society, doctors, and organ donation rate was low. But since 2021, everything has increased, and then the numbers have gone significantly up. And in this year already we have completed 4 heart transplantation. How the heart transplantation is different from rest of the liver and the kidney transplantation, that needs to be understood. Important thing is, again, heart transplantation is purely a cadaveric transplantation. You cannot have a live transplantation. That is, in liver and kidney, a live donor can give an organ. But in heart transplantation, it is purely cadaveric. Second thing is, heart transplantation normally doesn't give a second chance. If your organ is not good or the recipient is not optimal, then definitely the outcomes are not good. So selection of organ and selection of recipient is very important in heart transplantation, and normally that is why we are very choosy. We have very short ischemia time. Ischemia time means once the heart is removed from the cadaver and re-implanted in the recipient, the time duration that we get is 4 to 5 hours. So you have to complete the whole process in that 4 to 5 years. So the distance matters, the logistics matters, because that is where the green corridors and flight transition of the organ takes place. That is how it is different from rest of the organs. In kidneys, the ischemia time is almost 24 hours. In liver, it is almost 12 to 14 hours. So that is the time period you get for the other organs. And now, because of the shortage of organ in Western countries, the new alternatives have come up, that is LVADs and total artificial hearts also. And obviously, last but not the least, the glamour is there in heart transplantation. That is the difference between the transplantation. Heart transplantation is basically not a surgery, I would say. It is the whole process. And the process starts from, first and foremost thing is to identify the patient who is a candidate, who is the right candidate for heart transplantation, till the long-term follow-up of that patient. The difference between a bypass surgery, a valve surgery and a transplant is, in bypass and valve surgery, you do the surgery and you can forget it. You don't have to even follow up the patients. Patients can be followed up at their physician level also. But in this case, after the surgery also, patient have to be in continuous communication and follow-up of the heart transplantation team. And you cannot just forget that patient, because a small issue, a small non-compliance at any small level can give a disastrous outcomes. So in heart transplantation, first and foremost thing is identifying whether the patient really needs. And for that, you have to identify, or you have to find out the patient whether the patient is really of advanced heart failure, chronic advanced heart failure. So what are the criteria for chronic advanced heart failure? So patient having severe symptoms of heart failure, NYHA class 3-4, EF less than 30%, isolated RV failure, non-operable severe valvular abnormalities, congenital abnormalities, persistently high BNP level or anti-pro-BNP level, episodes of pulmonary and systemic congestions, and the patient is being admitted repeatedly in the hospital for heart failure symptoms, patient is having intractable arrhythmias, patient having on cardiorespiratory exercise testing, VO2 max is less than 12. So these are the few criteria based on which you can stamp that patient is of chronic advanced heart failure patient. And obviously we all know that there are more than 100 criteria based on which the mortality of a heart failure patients depend. And you cannot have a very systematic analysis of the patient and can give a fantastic guideline that this patient is going to survive for 2 days or this patient is going to survive for 10 months. Because a lot of factors are there to get associated with mortality. And we all know that as the time goes in advanced heart failure patients, the mortality increases in a steep manner. By the end of almost 5 to 7 years, 50% of the patients, they die of advanced heart failure. So you need to identify the patient, find out the patient and give them option for the treatment. And unfortunately, if you look at the decade of outcomes of heart failure patients in last 2 decades, there has not been very significant increase in the outcomes, that is the 1-year survival, 5-year survival or 10-year survival. They have been almost merely the same, whether it was in 2000 or 2010 or 2020. there has been a very marginal increase in the survival rate. And very important thing is, in your day-to-day practice, you might have seen that in heart failure patients, intermittently they are fine. They have a good days in between, and then again suddenly they deteriorate significantly. So sometimes this may be a camouflage, or you may feel that the patient is improving on medical management, so let us continue on medical management. But then suddenly they deteriorate, and then there is a sudden cardiac death in this particular category of patient. So you have to identify that golden period wherein the patient is of advanced heart failure and patient is of multi-organ system failure now. Between that phase, that is the golden period, that is where you should refer that patients to a heart failure clinic, and that is where the patients will be identified, patients will be diagnosed for various form of treatment, whether it is a CRTD, medical management, heart transplantation or LVAD. So we will identify based on lot of investigations that we go through that, and then we decide that this form of treatment is right for that particular patient. So if you look at the guidelines, the ACC-HA guidelines and European Society of Cardiology guidelines, heart transplantation is class 1A indication. So there is no doubt about it that it is the established form of treatment across the world. In refractory heart failure patients, we know we don't have any other options, and we have to give that option of heart transplantation if he is not improving with the medical management, with the CRT or any form of therapy. Then you may have to keep that patient on temporary LVADs, and by the time that you get the heart, you can transplant that patient on, do a heart transplantation for that patient. But always the point comes is when the patient is an ambulatory patient, घूम फिर रहा है, patient is doing absolutely normal routine activities, normal day-to-day activities. In that case scenario, we have to identify the patient. Sometimes when you go according to the NYHA class, then that may defer the referral of that patients for heart failure, for the transplantations. So what you have to go through is subject that patient for cardiorespiratory testing, that is VO2 max or 6-minute walk test. In your routine clinics also, make this patient walk for 6 minutes and measure the distance. If the distance is less than 300 meters, or on cardiorespiratory testing, if the VO2 max is less than 12 ml per kg per minute, then it is an indication that their cardiorespiratory reserves are gone, and that patient should be subjected for heart transplantation. And if you go through ACC-HA guidelines, nowhere they have mentioned NYHA class. They have always mentioned the symptoms or the arrhythmias or VO2 max. So VO2 max is a very objective criteria, whereas NYHA class is always a very subjective criteria, because every patient will tell their history in their own way, and you cannot identify that patient is NYHA class 3 or 4. So you have to establish the diagnosis based on very objective criteria. Now looking at the type of pathology, what are the most common pathologies for which the heart transplantation is indicated? Then if you look at the pie chart of ISHLT, that is the American Society, and even the pie chart of our own hospital, the majority of the cases are ischemic dilated cardiomyopathy or idiopathic dilated cardiomyopathy. Yes, there are small number of patients for valvular disease, congenital disease, post-myocarditis, and even retransplantations. So age is not a contraindication or indications. Any age group patients can undergo transplantation. In our own series, 3 of our patients are between 10 to 20 years, 10 patients are between 20 to 40 years, and more than 40, there are 13 patients that we have operated. Yes, not all patients are candidate for heart transplantation. There are contraindications also. So first and foremost thing is the age criteria more than 65. PVR, that is when you measure the intrapulmonary pressure and the PVR is more than 5 is a contraindication. Systemic infection, malignancies, this all are contraindications. But very important point that I would like to bring to your notice here is, look at the red line, that is irreversible renal, hepatic and pulmonary disease. We all know that when the patient is of heart failure, ultimately his renal dysfunction, liver dysfunction is going to set in. Cardiorenal syndrome is going to set in. So once that creatinine starts creeping up, when the creatinine is more than probably 2, or probably it is more than 1.8 and 2, in spite of optimal medical management, the creatinines are not coming down, or bilirubin is more than 2, then they are a very high-risk candidate for transplantation and the outcomes are not good. So definitely again, the point to be stressed here is that window period is very important wherein the patient should be referred for transplantation. So there is a balancing act. A person should be optimally treated with the medical management, still the organs are okay and the heart is pretty bad. That is where the transplantation should be performed. And if you look at the length of stay in our patient group also, in 25 patients, majority of the patients have got discharged by 11th or 15th day, because this were the patient who had good organ system, rest of the organ system. But the patient who had a very long stay, 70 days or 35 days or 35 days, this were the patient who had some amount of renal dysfunction or who had some amount of pulmonary issues or had some hepatic issues. Their stay was longer than the normally well-selected patients. How the matching of the heart transplantation occurs? You just have to see only 2 points. One is the blood group matching and second is the weight matching. 20% weight. So if a person is of, a recipient is of 80 kg, cannot receive a heart of 50 kg person. 80 kg patient need to receive a heart of a person who is more than at least 65 kg of weight. Because it is just as simple as that. In Maruti car, a Maruti engine cannot be fitted in BMW and BMW engine cannot be fitted in Maruti car. So you have to manage that way. Again, the time period is very limited. Within 4 hours, you need to complete the whole process. So that is where I get a call, okay, there is a cadaver, and I finish off the procedure. The whole process takes place within 8 to 10 hours. I go there, retrieve the organ, bring the organ, do the surgery, and unclamping is done. So that is the time period in which almost 7 to 8 hours we complete the whole process. What is the surgical procedure? It's as simple as, on the contrary, I would say it's a very simple surgical procedure. CABG is more difficult than a transplant procedure from surgical point of view, because you have to just anastomose SVC, IVC, aorta, pulmonary artery and left atrium. These are all big organs and you have to use almost 30 or 40 or 50 stitches only. Whereas in coronary, the coronary arteries are just 1.5 or 2 mm arteries and you have to use 80 sutures. So surgically, transplantation procedure is not very difficult. It is not so challenging. After transplantation, most of the patients are on triple drug immunosuppressions for 1 year. After 1 year, steroids are stopped and they are on 2 immunosuppressive, that is MMF and tacrolimus drug. First year is very important because they are on 3 immunosuppressive drugs. So what is the most important complication in first year? Either rejection or infection. Because your immunosuppressive drugs have suppressed the immunity at a significant lower level, that they get opportunistic infections. So these are the major issues in the first year of transplantation. Once they complete first year, then over a period of time, their infection rate and rejection rates are significantly reduced. And if you see the chart also here, the rejection rate after 5 years are practically nil, and infection rate definitely is always there lifelong, but then it reduces after the first year. After long immunosuppressive for almost 10 years or 15 years, these patients may develop renal dysfunction, diabetes, they may develop malignancies in the form of lymphoma, skin malignancies, These are the few common malignancies that you can see in these patients if they survive for more than 15 years or 20 years on immunosuppressive drugs. So they are side effect of immunosuppressive drugs. These are the common infections within 1 month, 6 months and more than 6 months. I'm not going to go into detail. Now, how do you identify that patient is having rejection or not? The first and foremost thing is echo, ECG, patient symptomatology that will guide you that ejection fraction has gone down, so patient has got a rejection. But to confirm it, you have to do is the biopsy, and that is still the gold standard, that you go inside the right ventricle, pick a piece of myocardium and do a biopsy. But now the science is emerging to a level wherein we are planning to go for liquid biopsy. Liquid biopsy means you take the blood sample, and from the blood sample you identify that there is a rejection. Those cell-free DNA, then donor-specific antigens. So these are various modalities which are coming up and which will probably in future avoid doing biopsies also. These are the complication data for our SIMS hospital also. We did have 2 major rejections, 10 minor rejections, 3 patients with infection in the hospital. Even 8 patients in the COVID era had COVID infection, but none of that died because of COVID. 30-day mortality, 2. 1-year mortality, 2 patients. This is my data. So at the end of 3 years also, the mortality is 2. So overall outcomes, I would say 85% survival, 85 to 88% survival at 1 year is our data. And if you look at the world over data, 1 year survival is 90%, and the median survival, that is at the end of 12 to 14 years, 50 to 60% patients are doing well. And if you compare it with the liver transplant and the kidney transplantations, the data are similar. So there is no difference in long-term, short-term and long-term survival in patients of kidney, liver or heart transplantation. So you have to be rest assured, and you can freely advise for heart transplantation for these patients. This is a 38-year-old, after 38 years of transplantation, I met him in Nice when I went to France for a conference. After 38 years of transplantation, patient is doing fine. And in India also, we have few patients who have crossed now 15 years and 20 years of transplantation. I will just go through fast to few of the interesting cases in my series. This is a donor heart. We got this heart from Surat, but actually the donor was very suboptimally managed. And when we took that donor for retrieval in the operation theatre, his blood pressures and everything were low, had severe acidosis. So we had to give adrenaline to make him survive, and then we harvested the organ. And then when we implanted the organ inside the recipient, when we unclamped the heart was not at all moving. You can see an echo. It is hardly 10% or 15% pumping. And that itself is a nightmare for us. But we knew what the reason is. There is no rejection. It is just that the organ was not optimally optimized nicely. So what we did is we put that patient on an ECMO, again an LVAD, a fantastic life-saving device. And that patient was put on an ECMO. On second day, the heart started moving. And you can see that now ejection fraction is somewhere around 25-30%. And at the end of 6th day, the patient was back to 60% ejection fraction. And we removed the ECMO, and this is the patient after 5 years of transplantation. He has completed 5 years of transplantation, and he is back to his routine activities also. This is another patient who has completed almost 4 years of heart transplantation, doing exercise, routine activities. He is back to his work, and even he can do his exercises also. This is our another patient who after 6 months of heart transplantation joined his LIC office, and he is a manager there, working actively right now in LIC office. This is our third heart transplant patient. He was a Muslim patient who received an Hindu heart, and 5 years post heart transplantation. Last year he had a kid also. So again, with immunosuppressive drugs also, he was able to conceive that kid also. So, and again, he is doing his routine activity at Anand railway station. He is a ticket giver there. This is our case number 10. We did it in the midst of the COVID era. In July 2020, when the COVID was at its peak, this patient was not improving with the medical management, and we were somehow we were forced to do a heart transplantation because we received an organ. With all the protocols that we made our own protocols, because world over there were no protocols how to perform a transplantation in COVID era. We devised our own protocols and we successfully did this heart transplantation. And in fact, that was the first heart transplantation across India in COVID era. So after that, many transplantations occurred, but yes, that made a landmark in the India also. This is our case number 12. He had a Marfan syndrome, underwent Bental procedure in 2017. Gradually his EF went down and his EF was 10 to 15%. So he had no other option, so we had to redo surgery. We did heart transplantation and patient is doing fine. He is almost 1 year post heart transplantation. This is very special case, post-COVID myocarditis in June 2021. We treated her medically, did not improve, so we transplanted her in December 21 and patient is doing fine. This is our 6th heart transplant patient. Back to routine activities, doing trekking and hiking. He even completed half marathon last year. So again, with ejection fraction of 60%, you can be back to routine activities. These are our youngest patients, 13-year and 14-year-old kids who have undergone heart transplantation, and they are also doing reasonably fine. So these are all our 25 patients collage that we have. And yes, again, the heart is beating and the life is continuing. That is one of the most satisfaction point for us as a cardiac surgeon, as a medical fraternity, that we are at least able to give a life, a decade or 2 decades life to a person who was supposed to die within 5 months or 6 months or 2 years. And last but not the least, let me tell you, heart transplantation is not the surgery. It is a combined effort of the whole team. The whole team may be comprising of almost 25-30 people, of which 15 are doctors, medical, paramedical staff, airport authority, traffic police, organ donors, NGOs, the help of which all these people only you are able to do a successful heart transplantation. So I think so I am fortunate enough to get that opportunity to give life, and with the help of all these people around me, we have been able to do a successful heart transplantation program at SIMS Hospital, Ahmedabad. Thank you very much, and I really appreciate your.
So thank you so much for your beautiful description, and I must say it's so knowledgeable and you all loved it. So can we have a big round of applause for Dr. Dhiren Shah. And once again, we would like to thanks to all our speakers, guests here. And the thanks is not enough, so we just have a small token of appreciation for you guys. So I would like to invite, first of all, I would like to invite Dr. Jitain Bapna. Please sir, come on the stage and present a memento to our speaker, Dr. and Professor P.C. Manaria. So do we have Dr. Ajit Bapna here? So instead of Dr. Ajit, I would love to invite Dr. Vitthal Das Maheshwari. And I request Dr. P.C. Manoria, sir, please come on the floor. Your experience and knowledge with us.
Thank you, sir.
Thanks a lot. We are so fortunate to have you here.
वेट सर सामने सर इधर कैमरा में
Colonel Arun Jain. So please come on the stage to present the memento to Dr. Dhiren Shah. So on behalf of everyone present here, we would like to thank you for coming all the way to the Jaipur and sharing your experience with us. Now I would like to request Dr. Radha Ramawat, please come up on the stage and present the memento to Dr. Abhishek Rajpopat.
सामने
Thank you so much, sir, for coming and sharing your experience and knowledge with us. We are so honored to have you here.
ओके मैम
And now I request Dr. Radha Ramawat to please stay here only. And she has done doctorate in yoga and meditation, and she is an author of a book which is titled Vibhinna Dharmo Mein Raj Yog Ki Upyogita. So she want to present her book to our dignitaries. So I request to all our dignitaries, please come over to the stage, and she would like to present her book to our dignitaries. Everyone.
सर सामने सर सामने देखिए सर थैंक यू
Thank you.
So regarding vote of thanks, I feel honored and privileged to get the opportunity to propose that vote of thanks in this special occasion of CME on cardiological topics. I would like to thank all the honorable delegates who blessed me with their presence. I am also very much thankful to all the invited speakers. Words are not enough. Words are not enough to thank their constant guidance and support to save the conference. If time is money, then today you have spent millions for me. Thanks to all of you for making this event successful.
Thank you so much, sir. Thanks a lot. Thanks to all of you for coming and making this event a wonderful. Thank you for being wonderful guests and wonderful speakers. Thanks a lot. And now you all enjoy the dinner and drinks. Have a wonderful evening ahead.
Ooh, yeah, beats made this.
tracks today.